speaker is Dr. Anju Nohria. Dr. Nohria is another member of our cardiovascular division at the Brigham. And she's the director of the cardio-oncology program with Dana-Farber Cancer Institute. She's a member of our structural heart disease division, heart failure doctor. And she's a associate professor of medicine at Harvard Medical School, a former medical school classmate. And she is going to be talking today about recent updates in heart failure. Dr. Nohria, take it away.
Excellent. Thank you, Chris, for that introduction. These are my disclosures. So over the next 45 minutes or so, I hope to provide you with guideline updates on the management of heart failure with reduced ejection fraction or an ejection fraction less than 40%. Updates on the management of heart failure with preserved ejection fraction or an ejection fraction greater than 50%, and then briefly talk about the management of acute decompensated heart failure. So these are data from the Get With the Guidelines for heart failure. If you look at patients who are hospitalized with heart failure, you see in the blue bars that about 35% have heart failure with reduced ejection fraction, 50% have heart failure with preserved ejection fraction, and then about 15% have heart failure with mid-range ejection fraction or an EF between 40 and 50%. In general, if you compare the baseline characteristics of patients who present with preserved ejection fraction versus reduced ejection fraction, preserved ejection fraction patients tend to be older, are more likely to be female, and have a higher prevalence of comorbidities such as hypertension, chronic kidney disease, and AFib. Interestingly, heart failure with reduced ejection fraction has a higher prevalence of coronary artery disease or ischemic heart disease, giving rise to systolic dysfunction. Patients with heart failure with mid-range EF behave more like those with reduced ejection fraction rather than those with an EF of greater than 50%. If you look at hospitalizations and mortality in the heart failure population by ejection fraction, you can see here that the 30-day mortality after a heart failure hospitalization is about 9%, regardless of your ejection fraction, and 30-day readmissions are about 20%, regardless of your ejection fraction. Unfortunately, the mortality after a single hospitalization for heart failure over 1 year is quite high and approaches about 60%, and patients are more likely to die from cardiovascular causes if they have HFrEF or reduced ejection fraction, and their all-cause mortality tends to be higher if they have HFpEF or preserved ejection fraction. So when we as heart failure doctors think about heart failure, we think about it in stages. Stage A are those patients who have risk factors for developing heart failure, but don't yet have any form of structural heart disease, meaning that their EF is normal, they don't have left ventricular hypertrophy, they don't have elevated biomarkers, etc. Stage B are those patients who have structural abnormalities, but have never had symptoms of heart failure. Stage C are those patients who have structural abnormalities and either have current or prior symptoms of heart failure. And stage D are those patients who have refractory symptoms despite best medical management and are people that you are considering for either mechanical circulatory support, transplant, or palliation. Whenever we think of hospitalized patients, we're mostly thinking about those patients with stage C or stage D heart failure, and that's why today I will focus my talk primarily on stage C heart failure. So when we look at the 2022 AHA-ACC guidelines for the management of heart failure, and you look at stage C heart failure with reduced ejection fraction or an EF of less than 40%, you are introduced to the 4 pillars of guideline-directed medical therapy. These include renin-angiotensin inhibition, beta blockade with one of the 3 approved beta blockers, namely bisoprolol, carvedilol, or metoprolol succinate. All beta blockers are not equally efficacious in heart failure, and therefore you should stick to one of these three: mineralocorticoid receptor antagonists, and then SGLT2 inhibitors. So these are the four pillars of heart failure management in patients with reduced ejection fraction. And then you should use diuretic therapy as needed for symptom relief. The two new kids on the block relatively are the angiotensin receptor neprilysin inhibitors, or ARNIs, also known as sacubitril valsartan or Entresto. And then SGLT2 inhibitors are also relatively new and have just made it into the guidelines in 2022. So let's explore the data behind these two new drugs. As you know, ARNIs are a combination of two medications, valsartan and sacubitril. We know that in heart failure, you have an excess activation of the renin-angiotensin-aldosterone axis. These molecules, namely angiotensin 2, acts at the AT1 receptor to promote vasoconstriction, activate sympathetic tone, activate aldosterone, result in progressive cardiac fibrosis, and at the level of the kidney, it causes sodium and water reabsorption to lead to symptoms of heart failure. The heart also secretes beneficial vasodilatory neurohormones such as natriuretic peptides, bradykinin, adrenomedulin, etc. These drugs have the opposite effects. They promote vasodilation, they combat the sympathetic and renin-angiotensin activation, and at the level of the kidney, they promote natriuresis and diuresis. So sacubitril valsartan blocks angiotensin 2's actions at the AT1 receptor with valsartan, and it prevents the breakdown of natriuretic peptides by inhibiting neprilysin, and therefore it decreases vasoconstrictive hormones and increases vasodilatory hormones, leading to net cardiac benefit. So the PARADIGM-HF trial was a trial that looked at sacubitril valsartan compared to enalapril in patients with heart failure with reduced ejection fraction, and it showed that sacubitril valsartan was superior in terms of reducing your likelihood of cardiovascular death or heart failure hospitalization, and the number needed to treat was 21 patients at 1 year. Sacubitril valsartan is a little bit more vasodilating than ACE inhibitors or angiotensin receptor blockers, so you have to make sure that patients have adequate blood pressure. They have an equal propensity for hyperkalemia and renal dysfunction, and like ACE inhibitors, they prevent the breakdown of bradykinin and therefore can increase your risk for angioedema. So what about patients with end-stage heart failure or stage 4 symptoms of heart failure? These were patients in the LIFE trial. This was a trial of patients with low EF, elevated natriuretic peptides. Most of these patients were intolerant of guideline-directed medical therapy, and many required an inotrope. And they looked to see if giving these people sacubitril valsartan compared to valsartan reduced their natriuretic peptide levels as a surrogate for improved cardiovascular benefit. And in fact, they found that there was no benefit with adding Entresto in these end-stage patients. And if anything, it caused more hypotension. And therefore, the guidelines do not recommend the use of an ARNI in NYHA class 4 patients with stage D heart failure. So what is the guideline recommendation? It's a class 1 recommendation that all patients should be on some form of RAS blockade in addition to beta blockers and mineralocorticoid receptor antagonists if they have chronic heart failure with reduced ejection fraction. If they have NYHA class 2 or 3 heart failure and adequate blood pressure, you should consider converting them from an ACE inhibitor or an angiotensin receptor blocker to an angiotensin receptor neprilysin inhibitor or sacubitril valsartan. In patients who are taking an ACE inhibitor, remember that both increase bradykinin levels. You don't want to give them back to back. You want to take the person off the ACE inhibitor, give them 36 hours to wash out the ACE inhibitor, and then start sacubitril valsartan. If the patient is on an angiotensin receptor blocker, you don't need that break between the two medications. And obviously, if your patient has a prior history of angioedema, just as you would not give them an ACE inhibitor, you would not give them an ARNI. What about the data for SGLT2 inhibitors? So there were two large trials. The first was the DAPA-HF trial. This is again a trial of symptomatic heart failure with ejection fraction less than 40%. Patients could have diabetes or not, and they randomized people to placebo or dapagliflozin 10 milligrams daily and found that dapagliflozin reduced the combined endpoint of cardiovascular death and heart failure hospitalization in these patients, irrespective of whether or not they had diabetes. The same was found in the Emperor Reduced trial, which looked at empagliflozin 10 milligrams daily versus placebo. Remember that these drugs can cause hypovolemia because they cause a glucose-mediated osmotic diuresis in these patients. So you may have to adjust your diuretic dose when you first start somebody on an SGLT2 inhibitor. They can increase your risk for urinary tract infections, particularly fungal infections and balanitis. And they have the risk of euglycemic ketoacidosis. So if you have a patient on an SGLT2 inhibitor, if they're going to be NPO for any reason, you want to advise them to stop their SGLT2 inhibitor at least 3 days prior to their procedure. In the Emperor Reduced trial, they also found that SGLT2 inhibitors reduce the rate of decline in eGFR in patients with heart failure with reduced ejection fraction. So it appears that these drugs may have benefits over and above their effects on heart failure. Now, why do we think that SGLT2 inhibitors are beneficial in patients with heart failure? As you know, they're drugs used to treat diabetes, so they reduce glucose-induced toxicity to the endothelium and the myocardium. They promote an osmotic diuresis, so they can have a reduction in plasma volume. They increase EPO production by the kidney and increase your hematocrit and oxygen carrying capacity. They have a mild effect on systolic blood pressure. They improve arterial stiffness. More importantly, they shift cardiac metabolism from glucose to ketone bodies and therefore make the heart more efficient. They promote a small degree of weight loss, reduce adiposity, reduce inflammation, and this is the basis for their cardiorenal benefits in patients with heart failure. So the guideline update says that if you have a patient with symptomatic heart failure with reduced ejection fraction, they should be on an SGLT2 inhibitor to reduce their hospitalization for heart failure and their mortality, regardless of whether or not they have type 2 diabetes. Now, many of us think, we keep piling on drugs on our patients. Is there really any benefit incrementally in terms of absolute risk reduction to being on 4 drugs versus 3 or 2 drugs? And this was a very interesting study that was done with a modeling exercise where they compared conventional therapy shown in the red lines with ACE inhibitors and beta blockers compared to a 4-drug regimen shown in the blue. And if your patient is between the ages of 55 and 65, if you give them 4 drugs compared to 2 drugs, you actually increase their longevity by about 8 years. If they're over the age of 65, you improve their longevity by about 6 years. So again, it's worthwhile to try and get your patients on these 4 drugs if they have the blood pressure room, are able to adhere to it, and of course, can afford these medications. So let's start with a case. This is a 53-year-old Black man who comes to see you after his first admission for acute decompensated heart failure. His ejection fraction is 25%, and he has a dilated left ventricle. He's on metoprolol, losartan, spironolactone, and furosemide. His vital signs are stable. He has mild hepatojugular reflux, clear lungs, a soft mitral regurgitation murmur, and no edema. His labs are notable for a sodium of 135 and a creatinine of 1.4, and he does not have diabetes. Which is the next best step to lower his risk of heart failure hospitalization? A, change his metoprolol succinate to carvedilol. B, change his losartan to sacubitril valsartan. C, add hydralazine and isodil. And D, do not add an SGLT2 inhibitor since he is not a diabetic. Please use your ARS systems to answer this question. So it's pretty clear that everyone got the right answer, which is B, change losartan to sacubitril valsartan. You would not change metoprolol succinate to carvedilol because if you use equivalent doses, the benefit is similar. You would not add hydralazine isodil at this point. You could consider adding it if he was on 4-drug GDMT and still symptomatic, because there is benefit in African Americans with hydralazine isodil, but that was on top of GDMT, and I'll go over that data later. And you would add an SGLT2 inhibitor to put him on a 4-drug regimen, even though he is not a diabetic. So the correct answer here is that you would change his losartan to sacubitril valsartan because sacubitril valsartan reduces heart failure hospitalization and improves mortality compared to ACE inhibitors or ARBs alone. So when you have a patient with heart failure with reduced ejection fraction and they are on their 4-drug regimen, you want to think about other things as well. So if they have class 1 to 3 heart failure and ejection fraction less than 35%, and they're going to live past 1 year, you should consider placement of a primary prevention ICD. If they have symptomatic heart failure, ejection fraction less than 35%, are in sinus rhythm and have a left bundle branch block morphology, their EKG, you should think about biventricular pacemaker placement. If for some reason they cannot take RAS inhibition, either because of renal dysfunction or because of hyperkalemia, you should think about putting them on hydralazine isodil, and I'll show you the data for this in a few minutes. African American patients, if they have adequate blood pressure room after GDMT, should also be considered for hydralazine isodil. And then if your patients are still symptomatic with all of these therapies, you could consider additional drugs such as ivabradine, intravenous iron replacement, fish oil, and vericiguat. So to briefly go over these data, the VHEF trial was a very old trial that was done out of the VA system in 1986. This was a trial where they looked at pure afterload and preload reducers in patients with heart failure. And they compared prazosin in the brown to placebo in the blue and found no benefit to pure vasodilation with an alpha blocker. However, when they gave the combination of isodil hydralazine and compared that to placebo, they found that you had a reduction in heart failure hospitalization and a trend towards improved mortality in these patients. When they went back to examine the patients enrolled in the VHEF trial, they found that Black patients in particular appeared to do much better with isodil hydralazine. And this led to the AHEFT trial in 2004. This took patients who self-identified as being African American, were already on an ACE inhibitor and a beta blocker, and randomized them to hydralazine isodil or placebo. And as you can see, hydralazine isodil had a significant impact on mortality in these patients. So if you have a Black patient who has adequate blood pressure after a 4-drug regimen, you should definitely consider adding hydralazine isodil. And again, if you have a patient who cannot tolerate RAS inhibition, either due to hyperkalemia or due to renal dysfunction, you should put them on hydralazine isodil to reduce heart failure hospitalization and have perhaps an impact on mortality. Ivabradine is a drug that inhibits the funny channel in the sinoatrial node. In patients in sinus rhythm, it lowers the heart rate without affecting contractility. Higher heart rates have been associated with increased mortality in patients with heart failure. And in the SHIFT trial, they showed that if you take patients who are in sinus rhythm and have a resting heart rate greater than 70 beats per minute, despite being on maximally tolerated beta blockers, the addition of ivabradine reduces heart failure hospitalizations, but has no impact on mortality. Now remember, it acts on the SA node, So these people have to be in sinus rhythm. You want to maximize beta blockade first because that has a mortality benefit while ivabradine does not. IV iron has also been shown to be helpful in patients with heart failure who have iron deficiency, regardless of whether or not they're anemic. Iron deficiency is defined as having a ferritin less than 100 or a ferritin between 100 and 300 with a percent saturation of less than 20%. If you give these patients IV iron, not oral iron, which tends to be poorly absorbed in patients with heart failure, you can improve their symptoms, improve functional capacity, improve quality of life, but it has no impact on mortality. Vericiguat is a soluble guanylate cyclase sensitizer. It improves nitric oxide bioavailability. This class of drugs is used commonly in patients with pulmonary arterial hypertension. This drug was studied in the Victoria trial, and basically they found that vericiguat reduced heart failure hospitalization but had no impact on mortality. So what is the sweet spot for using this drug? Someone who has recent worsening heart failure and a GFR of less than 30, so that they are not candidates for RAS inhibition or SGLT2 inhibitors, you could consider adding vericiguat to these patients to help reduce their symptoms and hospitalizations with heart failure. So going back to our case, our patient presents 1 month later with increased shortness of breath. He is now on a good 4-drug regimen with metoprolol succinate, sacubitril valsartan, spironolactone, dapagliflozin, and furosemide. His blood pressure is a little bit lower now that he's on all 4 drugs. His heart rate is 90. He has no evidence of jugular venous distension. His lungs are clear. He now has an irregular heart rhythm with a murmur of MR and no edema. His labs show mild worsening of his renal function with a creatinine of 1.6 from previously 1.4. He has a hemoglobin of 10. His iron is 25, TIBC is 150, and ferritin is 300. So what would be the next best step in his management? A, add ivabradine. B, give him IV iron infusions. C, add vericiguat. D, start apixaban and plan for a cardioversion in 3 to 4 weeks. Please go ahead and give your answers. Okay, so most of you got this right. The correct answer is D, start apixaban and plan for cardioversion in 3 to 4 weeks. So this is a guy who comes in with sort of recent worsening of symptoms. He's not massively volume overloaded, and the new finding on his exam is AFib. The atrial contraction actually contributes about 25% of your cardiac output if you have heart failure with reduced ejection fraction. So restoring sinus rhythm in these patients can have a significant impact on their cardiac output and their symptomatology. And therefore, the correct answer would be that you would anticoagulate this person because you don't know how long he's been in AFib, and then plan for a cardioversion in 3 to 4 weeks. You would not add ivabradine because he's in AFib. Again, ivabradine acts on the sinoatrial node, so you have to be in sinus rhythm for ivabradine to be effective in these patients. He does meet the criteria for IV iron, so yes, you could give him IV iron. That is not a wrong answer, but the reason that he fell apart was the AFib, and therefore you would correct the AFib first before giving him IV iron. And although you could use vericiguat in this patient, he's not one of these patients who's been recently hospitalized, etc., and therefore vericiguat may not be the first thing you would think about in this patient. So previously, we had very few guidelines for the management of heart failure with preserved ejection fraction, but this has recently changed with some new developments in this field. We still recommend very tight blood pressure control in patients with heart failure with preserved ejection fraction. You want to optimize their blood pressure management to have a blood pressure less than 130/80. If they're in atrial fibrillation, you want to do adequate rate control, anticoagulation, and if possible, restoration of sinus rhythm to reduce their symptoms. There is new data to show benefit of SGLT2 inhibitors in improving heart failure hospitalizations and perhaps decreasing cardiovascular mortality. And then there is a 2B indication that mineralocorticoid receptor antagonists like spironolactone or eplerenone and sacubitril valsartan may be beneficial in improving heart failure hospitalizations in patients with an EF of between 40 and 55%. What you don't want to use are nitrates and phosphodiesterase 5 inhibitors like sildenafil routinely in these patients unless they have other indications such as ischemia or pulmonary hypertension because they have not been shown to improve exercise capacity or functional capacity in these patients. So the data for the SGLT2 inhibitors comes from two large trials, the DELIVER trial looking at dapagliflozin and the EMPEROR Preserve trial looking at empagliflozin. And as you can see in this meta-analysis, both of these drugs improve the combined endpoint of cardiovascular death and hospitalization for heart failure in patients with heart failure with a preserved ejection fraction or mid-range ejection fraction with an EF of greater than 40%. If you look at the endpoints separately, you can see that cardiovascular death barely achieved significance where the p-value was 0.052, but heart failure hospitalization was clearly reduced in these patients with a hazard ratio of 0.74. So that's why this has a 2A indication, primarily to reduce hospitalization and maybe to reduce cardiovascular mortality in patients with an EF greater than 40%. The TOPCAT trial looked at spironolactone in patients with an EF of greater than 45% and symptomatic heart failure. The trial was null with regards to cardiovascular death or heart failure hospitalization. However, this was a complicated trial that primarily recruited within North America and then in Russia and Georgia. And if you broke up the findings by geography, you saw that patients enrolled in America had a benefit in cardiovascular death and heart failure hospitalization, while people enrolled in Russia and Georgia did not. So this led to the question of whether the drug is beneficial, and we just didn't see it because they didn't randomize the appropriate patients in Russia and Georgia, or is in fact the drug a dud? So based on this, there is a 2B recommendation that you can think about these drugs to improve heart failure hospitalization or symptoms in patients with an EF greater than 45%. Similarly, sacubitril valsartan was studied in the PARAGON-HF trial. Again, in patients with an EF of greater than 45%, sacubitril valsartan was not found to be superior to valsartan. However, they did a combined analysis of PARADIGM-HF and PARAGON-HF, and as you can see by the red dotted line, they found that if your EF was less than 55%, you were likely to benefit from sacubitril valsartan compared to valsartan or an ACE inhibitor alone. And therefore, the guidelines now say that in people who are on the lower end of a normal EF, i.e. EF less than 55%, you can consider giving sacubitril valsartan to reduce heart failure hospitalizations in these patients. What about heart failure with mid-range EF? Again, there are very few data specifically looking at people with an EF of 40 to 50%, although a lot of the newer HFpEF trials do include these patients. But in general, the guidelines recommend that you treat them as you would someone with heart failure with reduced ejection fraction. What about some novel therapies for heart failure with preserved ejection fraction? So these are things that have not made it into the guidelines, but probably will in the near future. The first are the GLP-1 agonists. So these are drugs like semaglutide, liraglutide, etc. This was a trial called the STEP-HFpEF trial. This was a trial of symptomatic patients with an EF of greater than 45% and a BMI greater than 30. These people were randomized to weekly semaglutide or placebo for 1 year. And as you can see in panel B, semaglutide, shown in the yellow, had a significant reduction in body weight in these patients. This translated into an improvement in your 6-minute walk distance and an improvement in quality of life. Importantly, C-reactive protein also went down in these patients, showing that semaglutide improves inflammation. And then recently, the trial conductors also did an analysis where they looked at NT-proBNP in these patients and showed that semaglutide reduces NT-proBNP levels as well, suggesting that the benefits of these drugs in patients with HFpEF may be over and above their weight loss benefits. These drugs are also being studied in patients with heart failure with reduced ejection fraction, and there are also mortality trials ongoing, and we're waiting for those results. The other trial that was recently published in the New England Journal in September is the Fine Arts HF trial. This was a trial looking at the non-steroidal mineralocorticoid receptor antagonist finerenone in patients with an EF of greater than 40%. So these were patients who were older than 40 years, had an EF above 40%, had symptomatic heart failure, and they were randomized to finerenone or placebo. Most of them were on a beta blocker and a RAS inhibitor at baseline. And what they found was that finerenone reduced heart failure hospitalizations, shown here in panel B, but did not have an effect on cardiovascular mortality. So again, it appears that a non-steroidal mineralocorticoid receptor antagonist could be considered to improve heart failure hospitalization in patients with mid-range or preserved EF. So shifting gears to talk about inpatient management, as I mentioned, we think about heart failure structurally in terms of stages. However, when we look at the patient in front of us, we think about them in terms of their symptoms. And this is where we get the New York Heart Association classification. So class 1 are those patients who have no symptoms or no limitation. Class 2 are those people who have mild symptoms with moderate exertion. Class 3 are those people who have symptoms with minimal activity. And class 4 are those patients who are symptomatic even at rest or cannot even perform their ADLs because of their heart failure. By definition, if you're stage B heart failure, you are NYHA class 1. If you're stage C, you can be class 1, 2, or 3, depending on how compensated or decompensated you are. And if you have stage D, by definition, you have NYHA class 3 or 4 symptoms of heart failure. So we will focus on NYHA class 3 and 4 patients who tend to be admitted to the hospital. I would like to warn you that there are very few randomized clinical trial data to guide the management of acute decompensated heart failure, and whatever I say is primarily driven by expert consensus. So going back to our case, our patient presented 3 months later with dyspnea with minimal exertion. So he's NYHA class 3, and he's had a 10-pound weight gain despite the fact that you doubled his diuretics as an outpatient. He remains on his 4-drug regimen with furosemide, now 160 BID instead of 80 BID, and he is on apixaban for his history of paroxysmal AFib. His blood pressure is much more marginal with a narrow pulse pressure. His heart rate is 90. His jugular veins are distended to the angle of the jaw. He has clear lungs. He has an S3. His liver is palpable 2 centimeters below the costal margin. He has trace edema, and he's lukewarm to the touch. His labs show progressive hyponatremia and worsening renal function now with a creatinine of 1.8. So when you see someone like this who's presenting with acute decompensated heart failure, you need to think about the following. 1, you want to see why he went into acute decompensated heart failure. If there is a reversible cause, you want to attend to that cause and take care of it. You want to optimize his volume status to improve his symptoms, and you want to make sure that he has adequate end organ perfusion. Once you have diuresed the patient, you want to make sure that they are on an optimal oral heart failure regimen with 4-drug GDMT prior to discharge, if possible. You want to manage any related risks, such as sudden cardiac death or venous thromboembolism. So you want to make sure that if they qualify for an ICD, they have that, or CRTD, they have that. If they have a history of VTE or LV thrombus, they're on anticoagulation. You want to educate the patient for signs and symptoms of decompensation, about their diet, about sodium and fluid restriction, and about weighing themselves daily. And if you have access to a longitudinal disease management program, you want to enroll your patient because these have been shown to improve outcomes in these patients. So just to go over these in a little more detail, precipitating factors can include ischemia, poorly controlled blood pressure, arrhythmias, infections, certain medications, non-adherence to medical therapy or diet, excessive alcohol intake, hypo or hyperthyroidism. And just because someone has heart failure, you don't want to not think about other causes that could be causing them to have their symptoms. I would like to draw your attention to concomitant medications that can worsen heart failure. And these importantly include NSAIDs, steroids, TZDs such as ranolazine, and L-type calcium channel blockers with negative contractile effects such as diltiazem and verapamil. So if your patient is on these medications, you want to discontinue them. And especially with NSAIDs, you want to warn your patients that those promote sodium and water retention at the level of the kidney, and therefore you should encourage Tylenol use rather than NSAID use for pain in these patients. So when you see a patient with symptomatic heart failure or acute decompensated heart failure, you want to ask yourself 2 questions. 1, do they have evidence of volume overload or are they congested? And 2, do they have adequate perfusion? So common signs and symptoms of congestion are elevated neck veins, hepatojugular reflux, peripheral edema, presence of an S3, symptoms of dyspnea on exertion, orthopnea, rales, and recent weight gain. And then, of course, lower extremity edema, as I mentioned before. Symptoms of poor perfusion are hypotension, obviously, low pulse pressure, so the difference between the systolic and the diastolic is reduced. Cool proximal extremities, so not hands and feet, but your more proximal extremities. Decreased urine output or altered mental status, suggesting poor end organ perfusion. If they're not responding adequately to IV diuretics, or if they have worsening pre-renal azotemia, meaning rising BUN relative to their creatinine. Now, the ESCAPE trial was a trial that compared outcomes in patients who were managed based on clinical exam or with a PA catheter in place to look at invasive hemodynamics. The primary endpoint of the study was negative, suggesting that PA catheter use routinely in patients with acute decompensated heart failure was not associated with a benefit. However, they compared your clinical exam findings to hemodynamic findings, and they found that elevated JVP was the single best physical exam finding to tell you whether or not a patient is congested. And we are always relying on rales and edema, but in people who have chronic heart failure, only about a third of them will have rales and edema. And that is because most patients develop significant lymphatic compensation over time, and therefore they may not present with rales and edema, even though they could be massively volume overloaded. So in medical school, we were all taught to lay your patient at an angle of 30 degrees and then to measure the distance of JVP above the angle of Louis or the sternal notch. I will tell you that in most patients with decompensated heart failure, their neck veins are so high that you cannot see them if you lay a person down at 30 degrees. And therefore, you may be fooled into thinking that they are not volume overloaded. So what you want to do is sit your patient bolt upright at the edge of the bed. And if you see their neck veins above the level of the clavicle, then you know that they are volume overloaded. What about natriuretic peptides? So there were two large trials, the Breathing Not Properly trial and the PRIDE trial. Both of these looked at natriuretic peptides in patients who presented to the ED with dyspnea of unclear etiology. And they found that if your BNP was normal, you were unlikely to have heart failure as the cause of your dyspnea. However, if you had heart failure, your BNP was likely to be elevated. But remember, BNP can be elevated in other diseases as well, and therefore it has high negative predictive value, but low positive predictive value for making a diagnosis of heart failure. And therefore, the guidelines recommend that you could use natriuretic peptides to support or exclude your clinical diagnosis, but you should not use these by themselves to make a diagnosis of heart failure. And this is because, again, it is an imperfect surrogate for filling pressures. BNP levels go up with age. Women tend to have higher levels. If you have pressure overload, such as with aortic stenosis, your BNP can be elevated. BNP is cleared by the kidneys. So if you have kidney failure, your BNP can be elevated. And in patients where BNP is most useful, such as those who are obese, unfortunately, adipose tissue breaks down BNP. And so they can have normal BNP levels despite being massively volume overloaded. HFpEF patients can be volume overloaded, but tend not to have elevated BNPs to the same extent as those with reduced EF. If your ventricle is remodeled and dilated, your BNP will never be normal, even if you are completely compensated. And then other diseases such as ischemic disease, pulmonary embolism, even sepsis, pneumonia can all raise your BNP to some level. Remember that sacubitril valsartan prevents the breakdown of natriuretic peptides, so BNP levels will be high in anybody who is taking sacubitril valsartan. However, NT-proBNP is an N-terminal cleavage product, and that tends to be predictable in patients who are taking Entresto, and therefore you should only measure an NT-proBNP in patients on an ARNI. So what about diuresis in a patient who comes in with acute decompensated heart failure? Loop diuretics are the mainstay. You could give them either as an intravenous bolus regimen given multiple times a day or as a continuous infusion. The three loop diuretics that are most commonly used in practice include furosemide, torsemide, and bumetanide. In general, torsemide and bumetanide have a longer half-life than furosemide. 80 milligrams of oral furosemide has equal potency as 40 milligrams of IV furosemide. This is equivalent to 20 milligrams of torsemide given PO or IV and 1 milligram of bumetanide given PO or IV. In general, if someone comes in, you want to double up their dose and give it IV. So if they take 80 milligrams of PO furosemide at home, you want to give them 80 milligrams IV. So that's double the dose given intravenously. You want to give it frequently to prevent intermediate time periods where they can absorb salt and water. And if the patient has renal insufficiency and a high BUN, you have to give higher doses of loop diuretics because loop diuretics enter the tubule through the same receptors that are bound by organic anions. So you have to compete with those receptors and you have to use a higher dose of diuretic therapy. In general, aldosterone antagonists are weak diuretics and you don't want to use them for diuresis, but mostly for their case-sparing and neurohormonal benefits. So the DOSE trial was a trial that looked at low-dose versus high-dose diuretics given either as a bolus or as a continuous infusion to patients presenting with acute decompensated heart failure. In the low-dose arm, people got the same dose that they were taking orally, or they got 2.5 times their oral dose, and they were either given the drugs as bolus BID or as a continuous infusion. And what they found was that patients who got high-dose diuretics had a faster natriuresis, faster diuresis, faster weight loss at the expense of slight worsening of their kidney function in the hospital. But at 60 days, there was no difference in death, rehospitalization, or ED visits. So what this showed you is that it is safe to use high-dose diuretics when someone comes in the hospital to get rid of the fluid faster. However, there was no difference between a bolus or a continuous infusion, and therefore you could use either strategy to diurese your patient. Now, in general, we know that wedge pressure has a greater impact on your long-term outcomes rather than cardiac index. Obviously, if your cardiac index is at the extreme, you're in cardiogenic shock, that's not a true statement. But for people who are moderately low perfusion but are very wet, getting them dry has a bigger impact on their long-term outcomes and mortality. So in general, you want to lower your person's filling pressures to the maximum possible before you discharge them home. You want to aim for a JVP less than 10, which means that when they are sitting bolt upright, you should no longer be able to see their neck veins above the level of the clavicle. If they have a lot of edema, you want to give time for that edema to re-equilibrate into the vasculature, and you want to be able to get rid of all that fluid to the extent possible. If you send people home wet, they will come back and rebound into the hospital. Usually your JVP is about half your wedge pressure. So the motivation for these standards is that when you are aiming for a JVP less than 10, you're basically aiming for a wedge pressure less than 20. Now, if someone has right-sided heart failure, that relationship becomes closer to 1-to-1. So you really don't want to over-diurese those people. You want to allow their JVP to be a little higher, like 12 or so, because you have to allow passive filling from the RV to the LV in those patients. What about home diuretics? So as I said, torsemide tends to have a longer half-life, and many people believe that after a patient is hospitalized, they're better off being discharged on torsemide rather than furosemide. This was a pragmatic trial looking at exactly that question, and they found that torsemide offered no benefits at 30 days or at 1 year relative to furosemide when you discharge patients from the hospital. One of the criticisms of this trial is that they did not regulate what you did with the diuretics once the people left the hospital. So we actually don't know truly whether torsemide might be beneficial in the outpatient setting because of its longer half-life. So our patient comes in, we give him 200 milligrams of IV furosemide twice a day. He does very well. He puts out 1 liter of urine on the first day. We repeat the same treatment on the second day, but now he doesn't put out so well, and his creatinine goes up from 1.8 to 2.2. So what are your options at this point? So when we think of a hospitalized patient, we should think of them in 3 trajectories. The first trajectory, shown in the green, is a person who's responding very well to IV diuretics. You continue to diurese them till they become euvolemic, and at that point, you transition them to a good oral regimen that maintains their weight. And I usually recommend keeping them in the hospital for 1 day on an oral regimen to make sure that you have the dose right. In the yellow are the second patient, like our patient, who does well initially, but then the urine output starts to drop off. So what can you do? You can double up their diuretics, and you can consider adjunctive therapy in these patients. So there have recently been several trials looking at adjunctive therapy. The first was the ADVOR trial. This was a trial looking at acetazolamide given intravenously along with loop diuretics in patients admitted with heart failure, regardless of EF. And what they found was that acetazolamide improved your likelihood of being adequately decongested at 72 hours compared to placebo. The caveats of this trial are that 1, you had to be on low-dose Lasix in order to be in this trial, and most refractory patients tend to be on higher doses of Lasix. And you could not be on an SGLT2 inhibitor, which also promotes diuresis within the proximal tubule, like acetazolamide. So in the current era where all of our patients are on an SGLT2 inhibitor, it's unclear whether acetazolamide has any place in the management of acute decompensated heart failure. The chlorotic trial looked at the same thing, but with hydrochlorothiazide. What they found was that you did promote weight loss and diuresis with the addition of hydrochlorothiazide, but you also worsened renal function and promoted hypokalemia in these patients, and there was no benefit at 90 days in terms of mortality or heart failure hospitalization. The Dictate AHF trial looked at whether it's safe to start dapagliflozin early in patients with acute decompensated heart failure. And they found that if you did, you improved weight loss, you improved diuresis, and in fact, the SGLT2 inhibitors may have a mortality benefit, and therefore you should think about adding these drugs even in patients with acute hospitalization. So this was also shown in the DAPA Resist trial, where they compared dapagliflozin to metolazone, and metolazone was more effective, but dapagliflozin had a mortality benefit. So in general, we would conclude that thiazides are probably the most effective adjunct decongestive strategies, and we normally use metolazone or diaryl in these patients. But remember that you are doing this at the expense of electrolyte and renal abnormalities with no mortality or rehospitalization benefit. So we gave our guy metolazone. He put out well, but his kidney function worsened, and then he had transient hypotension. So what did we do? We started peeling off his GDMT. We took him off his metoprolol. We took him off his Entresto, but he had no benefit. And so now he is in trajectory 3, shown in the red, where he is not improving and worsening despite escalating diuretics and other decongestive strategies. So this is a person where you might want to consider inotropic support or hemodynamic monitoring. So the trial looking at low-dose dopamine was the ROSE trial, where they gave people low-dose dopamine, and they found that there was no benefit in terms of urine output or change in cystatin C. There was also the ESCAPE trial that looked at routine use of PA catheters and found no benefit. However, PA catheters can be used in someone like our patient who has hypotension or worsening renal function with empiric therapy. Or anyone who comes in with cardiogenic shock should get a PA catheter. If the person is started on an inotrope and you can't take them off, you should consider a PA catheter. If they're being evaluated for advanced therapies, you should think about a PA catheter. And if they have pulmonary arterial hypertension, you should think about a PA catheter. So we want our patients to be warm and dry. That's the gold star. If they are wet but hypoperfused, if they're wet and have good perfusion, you want to dry them out by using loop diuretics. If they're wet and hypoperfused, you want to first improve their end organ perfusion. And if they have adequate blood pressure or a high systemic vascular resistance on PA catheters, you want to use an IV vasodilator like nitroprusside or nitroglycerin. If they have a low or normal SVR or blood pressure, then you want to use an inotrope, and you can use dopamine, dobutamine, or milrinone. But remember, milrinone is a more potent dilator than dobutamine, so patients should have an adequate blood pressure or a high SVR before you think about using milrinone. And if they're dry but underperfused, you just want to warm them up. Once you've warmed up a patient, you want to dry them out with diuretics like you would any other patient with decompensation. In general, avoid using inotropes because they increase oxygen demand, they increase ischemia, they increase the risk of arrhythmias, and are associated with increased mortality. So our guy got a PA catheter. His filling pressures were high, his cardiac index was low, his SVR was high. We tried IV nitroprusside, but he became hypotensive, so we switched him to IV milrinone. He did well, but we couldn't get him off IV milrinone. So now he was inotrope dependent. This is the kind of patient that you want to refer to a heart failure specialist for consideration of advanced therapies. And this is a list of things that should think about high-risk patients who you should refer to a heart failure specialist. So if they have worsening renal function, if you are peeling off GDMT, if they have intolerance of GDMT, if they cannot diurese despite escalation of medications, progressive hyponatremia, RV dysfunction, these are all patients that you want to send to a heart failure specialist for further evaluation. So When you discharge a patient, make sure that they are dry, make sure that you've started them on GDMT, make sure that you've given them good instructions and enroll them in a disease management program. Disease management programs such as home visiting nurses or a heart failure clinic improve mortality. If you have a patient who's very difficult, you can think about an implantable PA catheter guidance to help you manage their volume status outside the hospital. And this has been shown to reduce heart failure hospitalizations regardless of EF. And so in summary, make sure that you optimize GDMT. You can think about additional therapies in patients to reduce heart failure hospitalizations. HFpEF, there is now data for SGLT2 inhibitors and perhaps for semaglutide and finerenone to reduce heart failure hospitalizations. Acute decompensated heart failure is a clinical diagnosis, and you can think about BNP as an adjunct to support your diagnosis, good negative predictive value, bad positive predictive value. Try to diurese your patient to the optimal before discharging them, otherwise they will come back. Avoid using inotropes routinely. Get your patients enrolled in a longitudinal follow-up program and think about devices such as the CardioMEMS device if they're patients with recurrent hospitalizations. And if you have someone who has resistant heart failure, worsening renal function, withdrawal of GDMT, refer them to a heart failure specialist. Thank you for your attention.
Great. Thank you so much, Anju. This is a great talk, great update as always. Just time for a couple questions. We have one, actually two kind of related questions. One, at discharge, what do you recommend in terms of the order of GDMT addition if a patient has HFR, EF, and has a low blood pressure?
So if they have a low blood pressure, SGLT2 inhibitors don't tend to have a significant impact on blood pressure, nor do mineralocorticoid receptor antagonists. Beta blockers also depends on which one you use. So carvedilol is more vasodilating than metoprolol succinate. So you could put the person on metoprolol succinate. And then ARNIs are much more vasodilating than ACE or ARB. So rather than like aiming for an ARNI, I would say you're better off putting your patient on a low dose of ACE and ARB. And the general feeling is that your patient is better off on a little bit of everything than maximum of one thing.
Great. And then what would you define as an adequate blood pressure in a patient with systolic heart failure, reduced ejection fraction?
I mean, technically, you want them to have a systolic of 100 or more, but I would say many of our patients have a systolic of 90 or more. So as long as they're not dizzy or lightheaded, I tolerate anything above 90, but ideally you want them to have a systolic of 100 or more.
Great. Well, thank you so much. In the interest of time, we'll stop there, but thanks again for coming, and I hope to see you again next year.
Thank you.
Thanks.